Heart failure does not begin with obvious collapse. It begins with early physiological shifts that feel ordinary enough to overlook. These changes are small, but they reflect measurable disruptions in circulation, oxygen delivery, and pressure regulation that occur long before a diagnosis is made. What makes them critical is not their intensity, but their consistency. They appear quietly, blend into routine activities, and are often misattributed to lifestyle, stress, or age. Recognizing these early signs allows detection at a stage when the heart is still responsive to intervention, and this early recognition can significantly alter long-term outcomes. Here are 3 clinically significant signs that can indicate your heart is losing functional strength, signals that deserve attention long before they reach a critical stage. 1. Persistent fatigue. Fatigue is one of the most common early clues of a weakening heart, yet it's also one of the easiest to overlook because it blends seamlessly with everyday life. The difference is that cardiac-related fatigue doesn't behave like the tiredness caused by a long day or poor sleep. It develops quietly, maintains a steady presence, and gradually detaches itself from the amount of work you actually do. You may notice that a task you never thought twice about suddenly feels heavier, not in terms of physical strain, but in the sense that your energy never resets to its previous normal. This mismatch between effort and exhaustion is what makes early heart-related fatigue clinically meaningful, even when everything else appears stable. This specific pattern emerges because the heart, during the early stages of functional decline, begins to deliver slightly less oxygenated blood to the muscles and tissues. The body compensates by diverting blood preferentially toward vital organs, reducing supply to areas involved in movement and stamina. Even this subtle redistribution creates a measurable shift in energy availability. What surprises many people is that these adjustments happen before any dramatic symptoms, making fatigue the first noticeable deviation. It is not loud, alarming, or sudden. It is simply consistent. Unlike general tiredness, this type of fatigue has several recognizable characteristics. It becomes more persistent with routine activities, not necessarily intense ones. It often appears even after adequate rest, and it lingers throughout the day with minimal fluctuation. This shift in behavioral patterns, choosing elevators instead of stairs, taking longer breaks, or avoiding small physical tasks, is frequently an early subconscious adjustment. Recent studies have brought more clarity to this sign. Several investigations using cardiopulmonary testing and early biomarker detection have shown that reduced cardiac output in preclinical heart failure correlates strongly with sustained low-grade fatigue. The surprising insight from these studies is that measurable fatigue often appears years before classical symptoms such as swelling or chest discomfort. Researchers now consider fatigue one of the earliest external indicators of reduced cardiac reserve. More importantly, imaging studies reveal that many patients with persistent disproportionate fatigue have subtle structural or functional heart changes, including early diastolic dysfunction or reduced myocardial strain, changes that were once thought to appear only in later stages. Identifying whether your fatigue aligns with this specific pattern requires careful observation. Ask whether the exhaustion you feel matches your daily routine. If your activities haven't increased, but your energy has consistently declined, that mismatch becomes clinically relevant. Another identifiable feature is recovery time. Healthy fatigue resolves after rest. Cardiac fatigue tends to persist even after good sleep or light days. A third distinguishing factor is the shift in your energy threshold. If you notice that you reach a point of tiredness earlier in the day or after tasks that never affected you previously, your baseline energy may be reflecting early cardiovascular strain. These observations are crucial because they add context to what might otherwise seem ordinary. As the underlying issue progresses, this fatigue goes through identifiable stages. In the earliest stage, it is subtle and easily dismissed. Slight tiredness during routine tasks or general sluggishness at the end of the day. In the next stage, it becomes more noticeable during exertion, that never challenged you before, walking at your usual pace, climbing one flight of stairs, or carrying groceries. The third stage introduces delayed recovery, where even mild tasks leave you feeling disproportionately drained. In later stages, fatigue becomes coupled with other symptoms like breathlessness or mild swelling, but at that point, the heart's compensatory mechanisms are already strained. Recognizing the earlier stages is what allows timely evaluation long before structural changes progress. Clinically, this sign matters because it represents a decline in cardiac efficiency before measurable heart failure develops. Fatigue acts as the functional signal that something internally has shifted, even when numbers have not. For clinicians, persistent disproportionate fatigue prompts evaluation for underlying cardiac dysfunction, anemia, thyroid imbalance, sleep disorders, or metabolic issues, conditions that may imitate each other but require different interventions. Initial laboratory tests for this specific sign are relatively simple yet informative. A complete blood count helps rule out anemia, which can mimic cardiac fatigue. Thyroid function tests exclude hypo or hyperthyroidism. Basic metabolic panels evaluate electrolyte status. A blood natriuretic peptide, BNP test, can indicate early cardiac stress, even when routine evaluations look normal. If fatigue aligns with the clinical pattern described earlier, an echocardiogram becomes the next step to assess structural or functional heart changes. Sometimes, a cardiopulmonary exercise test is used to quantify how well the heart and lungs supply oxygen during effort. These tests help distinguish whether fatigue has a cardiac foundation or originates elsewhere. Management depends on the underlying cause, but in early cardiac-related fatigue, the goal is to improve cardiovascular efficiency and prevent progression. This includes stabilizing blood pressure, optimizing glucose levels, reducing inflammation, and balancing electrolytes if needed. If early diastolic dysfunction or strain is detected, medications may be recommended to support heart function, reduce workload, or improve relaxation of the cardiac muscle. Lifestyle adjustments have equal importance. Controlled physical activity, balanced nutrition, and sleep regulation strengthen cardiovascular resilience. Exercise management must be done strategically. High-intensity activity may initially worsen fatigue if the heart is under strain. Instead, gradual, structured, moderate-intensity movement is recommended. The goal is steady improvement, not rapid performance gains. Overexertion is counterproductive at this stage. The focus should be on maintaining stable cardiovascular demand. Diet plays a direct role in managing early fatigue linked to cardiac function. Emphasize foods that support vascular health and reduce sodium load. Vegetables, potassium-rich fruits, whole grains, lean proteins, nuts, and omega-3 sources. Limiting excess salt, processed foods, and high-sugar items reduces fluid retention and improves hemodynamics. Hydration must be balanced, not excessive, not inadequate, to maintain proper blood volume and electrolyte stability. A diet that supports consistent energy levels also reduces the metabolic stress that can worsen fatigue. Lifestyle habits require equal attention. Poor sleep, prolonged sitting, chronic stress, and smoking all magnify fatigue by placing additional strain on the cardiovascular system. Small adjustments, more sunlight exposure, structured activity breaks, breathing practices, and reducing stimulants enhance autonomic balance and indirectly support cardiac performance. Other conditions that produce similar fatigue include anemia, hypothyroidism, chronic kidney disease, adrenal dysfunction, depression, sleep apnea, chronic infections, and vitamin deficiencies. This overlap is why clinical evaluation is essential. Fatigue alone cannot identify the source. The difference lies in the pattern. Cardiac fatigue is persistent, disproportionate, and tied to subtle exertional decline. You should consider seeing a doctor when fatigue becomes routine rather than occasional, when it no longer reflects your activity level, or when it subtly increases over weeks or months without clear explanation. If this fatigue occurs with even mild shortness of breath, chest heaviness, dizziness, or swelling, medical evaluation becomes more urgent. Early assessment not. Assessment only identifies cardiac issues, but also rules out other conditions that may share this sign. And while fatigue often appears first, the next shift is even more revealing because it shows up directly in how effortlessly you breathe during the simplest activities. 2. Shortness of breath. Shortness of breath is often associated with advanced heart conditions, yet the earliest form is far more understated and easy to dismiss. It does not arrive as gasping, chest clutching, or breathless episodes. Instead, it begins as a mild reduction in the comfort of breathing during tasks that never challenged you before. The change is small, but the consistency with which it appears is the real indicator. The mechanism behind this early shortness of breath is straightforward, but clinically revealing. As the heart's pumping efficiency starts to dip, even by a small margin, the lungs receive slightly more pressure from the blood returning to them. This reduces the ease with which oxygen can exchange through the lung tissue. The body's natural response is to subtly increase breathing effort, often so gently that people describe it not as shortness of breath, but as breathing not feeling as smooth as before. This is the earliest form of dyspnea linked to cardiac function. This shift can appear even in people with normal blood pressure, normal ECG results, and normal weight, which is why relying solely on standard measurements often misses this early sign. It's the internal pressure change within the heart and lungs that triggers this sensation, not external factors. Identifying whether this early breath change is cardiac in origin requires paying attention to the context in which it appears. The earliest pattern is simple. The breath feels mildly heavier earlier than it used to. Maybe you used to climb a flight of stairs without thinking, and now, halfway through, you take a deeper breath, not because you are unfit, but because the lungs are compensating for reduced cardiac efficiency. Another clue is that this sensation often appears during transitions, standing up, walking after sitting, or carrying small items. These are moments when cardiovascular demand rises briefly, revealing underlying functional strain before the body resets. The third identifiable pattern is recovery time. If breathing takes longer to return to full comfort after routine exertion, even just walking across a room, that discrepancy becomes clinically meaningful. This sign evolves in stages. In the earliest stage, there is no obvious breathlessness, only a slight awareness of breathing during mild activity. Many people attribute it to humidity, tiredness, or a tight day, but its recurrence is what matters. In the second stage, this shift becomes predictable during specific tasks. Climbing stairs, bending down, or brisk walking. It's still manageable, but the ease you once had quietly disappears. In the third stage, the effort required to maintain comfortable breathing increases, even during moderate tasks, and recovery time becomes more noticeable. Only in much later stages, long after the earliest clues, does overt shortness of breath appear with rest, lying flat, or nighttime breathing discomfort. The earlier stages, though mild, are the most valuable for early detection. Even when the heart's overall pumping function appears normal on traditional tests, the functional efficiency during exertion may be compromised. The first set of tests used to evaluate this kind of symptom are simple and non-invasive. A chest examination helps detect crackles or changes in lung airflow. Pulse oximetry checks oxygen saturation at rest, although early stages often show normal readings. Basic labs include a complete blood count to rule out anemia, thyroid testing to ensure metabolism is balanced, and BNP to detect even minor elevations in cardiac stress. If shortness of breath has a cardiac pattern, these markers may show early abnormalities before symptoms intensify. An echocardiogram becomes the key test, as it reveals how well the heart relaxes and pumps, and whether there is early diastolic dysfunction or mild elevation in pulmonary pressures. When needed, a cardiopulmonary exercise test provides precise data by analyzing breathing patterns in relation to cardiac output during controlled activity. Managing this sign begins with identifying the underlying cause. If mild cardiac dysfunction is detected, early treatment focuses on reducing cardiac workload, improving vascular health, and optimizing pressure balance in the lungs. Medications may be introduced to support heart relaxation, reduce fluid buildup, or enhance blood flow efficiency. Even small adjustments in these areas can significantly improve breathing comfort because they reduce the pressure transmitted back into the lungs. Exercise must be approached carefully. The goal is to maintain cardiovascular conditioning without creating excess pressure in the heart and lungs. Steady, moderate intensity activities, such as controlled walking, cycling at an easy pace, and low impact resistance training, help increase oxygen efficiency without overloading the system. High intensity intervals or abrupt exertion are not recommended initially, as they may amplify early symptoms. Diet plays a measurable role in improving early shortness of breath linked to cardiac function. Lower sodium intake reduces fluid retention, which in turn decreases pressure on the heart and lungs. Foods rich in potassium, magnesium, and antioxidants support vascular flexibility and reduce inflammation. Maintaining stable blood sugar levels prevents metabolic fluctuations that can worsen breathing efficiency. Balanced hydration prevents both fluid overload and dehydration, each of which can affect cardiovascular dynamics. Lifestyle habits shape how this symptom progresses. Poor sleep, high stress, long sedentary periods, and smoking all strain respiratory and cardiovascular interactions. Prioritizing regular, physical movement, structured sleep patterns, and avoiding nicotine significantly improves breathing comfort. Even reducing alcohol can improve cardiac relaxation and nighttime breathing quality. Several other conditions share this sign, which is why clinical evaluation is essential. Asthma, COPD, anemia, obesity, deconditioning, anxiety disorders, respiratory infections, and thyroid disorders can all produce early shortness of breath. The key distinguishing factor is that cardiac-related breath changes worsen predictably with exertion that previously felt effortless and improve only partially with rest. You should consider medical evaluation if you consistently feel slightly breathless earlier than you used to, if recovery after routine activity becomes slower, or if breathing shifts without a clear cause like illness or environmental triggers. Immediate evaluation is needed if breath changes appear alongside chest pressure, unexplained fatigue, dizziness, or swelling. Early assessment can identify cardiac involvement long before advanced symptoms appear, allowing timely intervention and prevention of progression. But the body doesn't stop there. Once breathing patterns begin to change, the next sign surfaces right where pressure imbalances become visible from the outside. 3. Body swelling. Swelling is a symptom people often link to long hours of sitting, heat, or salt intake, but the kind associated with early cardiac decline has a completely different character. It develops slowly, appears at times when you wouldn't expect it, and carries a consistency that doesn't match daily patterns. The earliest form is subtle, slightly tighter shoes at the end of the day, faint marks left on the skin from socks, or a feeling of heaviness in the lower legs that wasn't there before. These changes may seem trivial, but clinically they reflect the moment the heart's pressure handling ability begins to shift, causing fluid to settle in tissues that normally remain balanced. The mechanism behind this is straightforward, but highly informative. When the heart becomes less efficient at managing the return of blood from the lower body, even by a small margin, pressure increases in the veins. This encourages fluid to move into the surrounding tissue. In the beginning, the body compensates well, so the swelling is mild and appears only at the end of the day. Over time, as the imbalance persists, the swelling becomes more noticeable and less dependent on posture. What makes this sign meaningful isn't the size of the swelling, but the pattern, its persistence, its subtle increase, and its failure to fully resolve. What may surprise people is how early this sign can appear. Newer studies using advanced imaging and biomarker tracking show that fluid retention can begin even before breathlessness or fatigue become obvious. Researchers have noted that in the initial phases of cardiac dysfunction, the body shifts how it handles sodium and water long before imaging shows major structural changes. A person may still have normal blood pressure and normal kidney function, yet very mild edema begins to appear because the heart's ability to maintain steady venous return is slightly compromised. This early stage is precisely when detection matters most, because it is reversible and highly responsive to timely intervention. Identifying the cardiac pattern of swelling requires observing how and when it develops. One of the earliest clues is asymmetry with activity. For example, the swelling may increase in the evening, even on days when you did not stand or walk much. Another clue is that elevation reduces the swelling, but not as efficiently as it used to. A third indicator is the quality of the swelling itself. It tends to be soft, leaves a brief indentation when pressed, and is more noticeable around the ankles, feet, or lower shins. In some individuals, the swelling shows first in the hands or around the abdomen as a vague sense of bloating or tightness, but the defining feature is that it persists day after day despite changes in routine. This sign progresses through clear stages. In the first stage, swelling is barely visible but can be felt as tightness. In the second stage, it becomes visible in the evening and reduces by morning, but not completely. In the third stage, swelling appears earlier in the day and takes longer to resolve, indicating more sustained fluid imbalance. Only later, when cardiac strain becomes more advanced, do we see swelling extending up the legs, accompanied by other symptoms. The earliest stage is the most easily overlooked, yet it is the most valuable for early diagnosis. Clinically, unexplained swelling is one of the most objective outward markers of rising venous pressure or early fluid retention. Even when heart function appears normal on routine tests, this sign can reveal underlying diastolic dysfunction, early right-sided strain, or shifts in hormone regulation responsible for fluid balance. Physicians view it as an important signal because the body does not retain fluid without reason. It reflects an imbalance between what the heart can return and what the vessels can handle. This makes swelling a functional clue that complements symptoms like fatigue or subtle breath changes. Initial evaluation begins with simple tests. A basic metabolic panel helps assess kidney function and electrolytes. A complete blood count ensures anemia isn't contributing to fluid shifts. Thyroid tests rule out hormonal causes of swelling. BNP levels indicate cardiac stress and help differentiate cardiac edema from other types. If swelling persists, an echocardiogram becomes essential to examine chamber pressures, valve function, and relaxation patterns. When necessary, ultrasound of the legs rules out vein problems that can mimic cardiac swelling. Together, these tests help pinpoint whether the swelling is cardiac, vascular, renal, or metabolic in origin. Management depends on the cause, but when early cardiac involvement is present, the strategy focuses on restoring pressure balance and improving fluid regulation. This may include medications that reduce congestion, enhance heart relaxation, or help the body eliminate excess sodium and water more efficiently. Small adjustments in these areas can lead to noticeable improvement, especially when swelling is still in its early stages. Exercise and movement must be structured thoughtfully. Regular low-impact activity supports venous return and prevents fluid pooling. Walking, gentle cycling, and light strength training improve lower limb circulation without overloading the heart. Sudden high-intensity activities are not recommended initially, as they can temporarily increase venous pressure. Elevation of the legs after long periods of sitting, ankle mobility exercises, and brief movement breaks throughout the day all support fluid management. Lowering sodium intake reduces fluid retention and eases pressure on the venous system. Adequate potassium from natural foods helps maintain balance between sodium and fluid distribution. Consistent hydration prevents the body from conserving fluid unnecessarily, which can worsen swelling. Including antioxidant-rich foods supports vascular integrity and reduces subtle inflammation that can aggravate fluid accumulation. Daily habits also influence how this sign evolves. Long sedentary periods promote pooling, so regular movement is essential. Wearing very tight clothing around the lower legs can worsen swelling. Poor sleep increases hormonal imbalance related to fluid retention. Alcohol, especially in excess, contributes to swelling by impairing fluid regulation. While none of these factors directly cause cardiac swelling, they amplify the early changes and make the pattern more noticeable. Several other conditions can present with similar swelling, including kidney disease, venous insufficiency, liver dysfunction, certain medications, hormonal imbalances, and localized injuries. This is why context and pattern matter more than the swelling itself. Cardiac-related swelling typically follows a consistent trajectory that does not fully reverse and gradually becomes more predictable. You should seek medical evaluation when swelling appears without a clear reason, when it returns daily, or when it gradually increases over weeks. More urgent evaluation is needed if swelling occurs along with breath changes, unexplained fatigue, chest pressure, dizziness, or rapid weight gain. Early recognition allows for targeted treatment, often preventing progression to more advanced stages. Understanding these three signs gives you a practical advantage, because the earliest shifts in heart function are subtle but measurable when you know what to look for. If any of these patterns appear consistently, timely evaluation can prevent progression and protect long-term cardiac health. For more clinically grounded, research-backed guidance, like, share, and